Okay, we'll go ahead and get started since we're a few minutes over, and I've been told to use the microphone. It's not my favorite thing, but we'll make it work. I hope everybody has had an excellent day at the conference, and we appreciate you being here for the last session of the day. My name is Alicea Reddy. I'm with the DEA. I'm a contractor doing work around the opioid crisis. I also work for the First Responder Support Network. Has anyone heard of that out of California? West Coast Post-Trauma Retreat. We do support services for first responders and their spouses who are suffering the effects of stress and trauma. Before this, I was a police officer, heavily involved in peer support and crisis intervention. So all of this is very near and dear to my heart. But today we're going to be talking about the opioid crisis. Has anyone had training specific to the opioid crisis? A couple hands. So this is something that's affecting every community. And unfortunately, even though that's the case, a lot of us in our professional roles only have bits of the puzzle of information, including what tools we can use to be a part of the solution to this crisis. So the hope in this course for you is to give you some general information about what the crisis is, and how we can use our critical incident stress management tools to be a part of the solution. Obviously, with all of the topics that are covered in this conference, there's the opportunity for us all to get triggered, right? By things that might exist in our professional lives, our personal lives, and the purpose of this session is just to provide information, to create a conversation. So I don't mean to trigger anyone. There are some videos that are a little bit triggering, so I just want to give that warning. If anyone needs to step out, that's fine. I'm here for questions, but I'm going to ask that we hold them to the end so we can get through the whole presentation. So we are in our roles are seeing the end results of this crisis. We're seeing it spill out onto the streets. We're seeing the effects of addiction and overdoses, but it didn't start that way, right? Who in this room is in law enforcement? Okay, what about fire, paramedic, medical services, social services? Great, so we have a full gamut. Who's had to respond to overdoses? Great. Why is it a crisis now? Who can tell us that?
It happens 10 times a day.
Exactly.
Once every 6 months.
Exactly. Perfect answer. This has always been a problem. This is not something new. The reason it's been labeled a crisis, an epidemic, a public health emergency is because of the rate of overdose deaths we're seeing in the US. Last year alone, in 2017, we had 72,000 overdose deaths in the US due to drugs. Of these, the most prominent cause is opioids. Who can tell us what an opioid is? Any answers? It's a prescription pain drug, right? Like Vicodin, Percocet, hydrocodone. You also have naturally occurring opioids that we call opiates, like heroin, even some of the chemicals in our body. When we look at these overdose deaths, a majority of them are being caused by fentanyl. I'm sure this is not the first time you're hearing about fentanyl. Fentanyl is a synthetic opioid, and we're going to dig a little deeper into that. But the other thing that we're seeing an increase in is heroin overdoses. Who can take a guess as to why that is? Cheaper, easier to access. Things are laced with fentanyl. All absolutely right answers. The estimate is that 75 to 80% of new heroin users started with a prescription pain medication. What this means is that most of the addicts that we're seeing started taking legitimate pain medicine for probably a legitimate ailment that was prescribed to them by a doctor, and with addiction became desperate to get access to those drugs, turned to the street either for counterfeit drugs, and then heroin, because heroin sometimes is a lot easier to access. And now we're seeing, of course, that drugs are laced with fentanyl. Like I talked about, this is not a new problem, but the overdose rates are what are causing the alarm. So it has been declared a public health emergency. We consume 80% of the world's opioid supply, 99% of the world's hydrocodone supply. We are not 99% of the world's population. We are 4.4 approximately percent of the world's population, and yet we're consuming all of these medications. The modern wave of this started about in the 80s, where we had prescription pain medicine that was being marketed for cancer patients, surgeries, severe acute pain. It was never really meant to be used for chronic pain. But who pushed that? Drug companies. And we're seeing the outcome of that now, not only with overdose deaths, but in some of the lawsuits that have been filed recently against drug companies and their responsibility in this. If you look at how we compare to other countries in terms of drug overdose deaths, we're at the bottom of that graph, far, far exceeding other countries in the world. And this is simply due to how we're prescribing medications, how this evolves into other addictions, and the response to that. So fentanyl. Fentanyl is produced legitimately as a pain medication for very severe pain, especially after surgeries. But what we're seeing is illicit fentanyl. Illicit fentanyl that's being produced predominantly in what country? Who knows? China. So it's two chemicals that really have no other purpose other than producing fentanyl, unlike meth, which includes chemicals and ailments that can be found in other things. So fentanyl is produced in China, both legitimately and illegitimately. The chemicals or the finished product are then sent to other countries, predominantly which country? Us, but through which country? How is it getting to us? Anyone know? Mexico, predominantly Mexico. So comes over and it's either already into other drugs or it's coming in as fentanyl and being mixed into the drugs here by local dealers. So it takes a very low dose. It's a very potent drug. You also have analogs like carfentanil. Anyone know what that's for? Elephant tranquilizer, large animal tranquilizer, very potent. So someone in the back mentioned it being laced in other drugs. So we're seeing this in meth, we're seeing it in cocaine. There's other drugs we're finding it in. Counterfeit pills. This is really, really tricky. People turn to the street when they can no longer get a legitimate prescription, and they're trying to buy pills. They don't know if the pills they're buying are actual legal pills that are being monitored, or if they're counterfeit pills. Counterfeit pills are not regulated. So there's no chemist monitoring how much of the fentanyl is in that pill. And that's really why we're seeing this increase in overdoses. This is why it's exceptionally dangerous that young people are experimenting with pills, especially at parties, and not knowing where these pills are coming from. It's incredibly easy to make. They have YouTube videos that show how to make fentanyl. You, on eBay, can buy a tablet making machine with different imprints to mimic the different pills. And your end product is a very profitable, very dangerous drug. Very profitable because it can be cut into other drugs to make your product go further, make you more money, it's more potent, right? So some people ask, but if it's so potent and it's killing people, isn't that not good for business? Who can tell us why that is good for business? From an addict's point of view, why they can get high. And for people that understand addiction and the course of addiction, you get to a point where you're no longer experiencing the high. And for people who are addicted, it might be the first time in years that they actually feel that high again. So if you talk to some people who are addicted, they're either desperately avoiding anything fentanyl related because they know how dangerous it is, or you have people that are seeking it out. And this is the result we're getting.
This is the most stressful part of the job, getting to the call.
Brian Tweets has no idea how many of the 914 deaths last year happened on his shift. The 30-year veteran paramedic refuses to keep count.
And there's a lot of times where it's just too late and we can't get their heart to restart.
How often is that in your case?
It happens frequently.
Twaits has special training in advanced life support and travels alone in an SUV to back up paramedics on complex calls.
Overdoses come in as a very critical emergency. In our system, they're not breathing and literally are quite close to death. We actually bring the emergency room to you in the street.
He carries a $40,000 monitor that will be useful on his next patient who is not breathing in a public washroom.
Excuse me. Yeah. She got the Narcan.
Twaits draws up the Narcan shot he hopes will revive her.
0.8 here. You want to take care of that? And I'll chart that on here so we have time on my monitor for you. It's going to be a couple minutes till she starts to wait here. Well, she was like pretty much face down. Okay. I'm just going to take that for a sec. Do you want to just check the back of her head? Just make sure we don't have any big bumps there.
This woman is fortunate. Her friends started to worry and found her here. A few more minutes alone in this washroom would have been too late.
Hi, hon. Hi, it's okay.
You're giving Narcan in here.
Okay, you're all right. Just relax.
Relax. Let me have your mouth. You pull that out.
Get the tube in your mouth. Pull out the tube. It still took probably about 5 minutes, I think, after the Narcan for her to wake up.
Her reaction to her very close call says it all.
He's just outside. Don't worry, we're not there right now. They haven't had a lot of oxygen circulating through their brain, so they're quite confused. And so they wake up confused in the middle, and in this case, of the bathroom floor, not knowing what's going on with a whole bunch of strange faces looking at them. And I would imagine I know I'd be alarmed.
Her frantic friend says he had also overdosed himself earlier in the day.
Kill some nerves and kill some stress or whatever. Went under and I didn't see it coming. And she went under for a little bit. But she's back now.
How long was she down?
I didn't take 30 minutes, 45 minutes. As far as when everybody showed up. And
What do you think of the paramedics who were able to revive her?
paramedics are awesome, man. Hey, great, guys.
Twain says she made the most deadly mistake a drug user can make. She used alone.
That's a sad thing. Nobody wants to die alone. And a lot of these people are, unfortunately.
Like this man who was long gone before anyone found him in a public washroom. Twain thinks death spiked in November and December because cold weather forced users indoors to use in places where no one will see them collapse.
Or somebody didn't phone 911 soon enough. I've seen cases where people that have gone running to find a Narcan kit instead of phoning 911. And, tragic outcomes because there's a telephone in the lobby of the building, but they elected to run somewhere else and find a Narcan kit.
His advice to loved ones is call 911 first, and dispatchers will tell you how to keep the patient alive until the paramedics arrive.
Narcan is great, but it's oxygen. The deprivation of oxygen is what's killing these people.
He also fears some users are afraid to call 911, afraid of police.
The police aren't worried about the fact that you've overdosed to get you in trouble. They're the same as us. They want to see you get some help. Okay, can't find them?
So they were up and breathing on their own, but there's nobody here.
His next patient took off before he got there, on a block where anyone in a uniform is not welcome.
Go around the other side. They're getting really agitated. We gotta go. There's stuff from. It's in every community, and it affects all walks of life. Addiction is a horrible thing.
And last month, it killed more than 4 people a day in BC.
It's frustrating that it's still happening, but really it's sad. It's sad that many people are dying and we haven't been able to get to them.
This shift alone, he attended 22 overdose calls. He shares his secret to getting through every one of them.
I always think back that whoever that we're dealing with, at some point was a little baby that was being bounced on somebody's knee, right? This is somebody's family. And that helps.
Okay, so like we talked about, the outcomes that we're seeing is not where things started. For most of these people that are suffering with addiction to opioids, they started as pretty normal functioning people, and for different reasons, became addicted to opioids. It may be, like we talked about, from some type of legitimate illness or injury in which they were prescribed drugs, and they trusted the advice from the doctor. It was advertised as not being addictive. Doctors were told this was a safe solution to pain, and obviously that was misrepresented, and we have people that get quickly addicted, and it's a very wicked addiction. You also have underlying mental health issues and underlying unresolved stress and trauma. And as is covered in other parts of this conference and we're all familiar with, the ripple effects of unresolved stress and trauma can be very deadly, including if there's substance use on board. And sadly, if there is a mental health issue, 2 times as likely that they're also going to be suffering from a substance use issue, and vice versa. Sometimes hard to know which is causing which. So let's talk a little bit about addiction. You have receptors all throughout your body that are opioid receptors. They are going to react to natural things in your body like adrenaline and endorphins. When you take pain medication, it's attaching to those receptors, and you're feeling a sensation of a relief of pain and a euphoria, physical and emotional. The problem with addiction is that when you become dependent on opioids, you have more receptors that are demanding that drug. You have your system flooded with the opioids and changing and hijacking your brain so that when that's not present, your perception is that you are dying, physically dying. So it is not somebody being dramatic when they're going through withdrawal. At the beginning, they're going to experience the high that comes with taking those drugs, but once they build a tolerance and they're needing to take more, they get the negative effects when it's not in their system. They're going through withdrawal, they're going through depression, and pretty soon they're taking the drugs simply to reach a baseline. They're no longer experiencing a high, they're just taking it to feel normal and not feel like they're dying. This is important to remember, and the people that you're coming across, or if you have even loved ones in your life that are dealing with addiction, it's really not as simple as telling someone to stop or to concentrate on the things that are important in their life, because what's happening physically in their body cannot be always overcome by willpower. And the ripple effects are going from individual addiction into how it affects families, infants being born to addicted mothers, how it impacts our medical system, transmittable diseases, and of course, public health concerns. In the cities that you work in, are you coming across needles on the street? Are you coming across people shooting up on the street, using on the street? And it's hard to know if they're on the street because of drug addiction, or if they were on the street and became addicted because they're homeless and on the street, right? It's all intertwined. And sadly, it's estimated that this is costing the US $78.5 billion a year, the opioid crisis. And a focus on treatment would be far less costly than what we're expending on just responding to the crisis that we weren't able to get ahead of. The other outcome that is very sad is the increased suicide risk that comes with people who are misusing opioids, especially among the veteran population. So how does this impact all of us in our responder roles? These are all terms you should be familiar with, especially related to CISM and peer support. When it comes to the opioid crisis, how are you experiencing secondary trauma when you're responding to calls? Who has an answer for that? If you're responding to someone's overdose, are you experiencing their trauma? Yes. If you're going to the same people who have overdosed over and over again, and you've taken them to the hospital over and over again, you're gonna get burnt out, you're gonna get desensitized. You're gonna stop caring and think that their life is a lifestyle and a choice, that they're choosing to be that way. It's easy to become desensitized to it and burn out with it. You experience critical incident stress by responding to these situations, and of course, you also now have the scare of being exposed to things like fentanyl yourself in your profession.
Is that shaking?
We would call this disturbed tremors. That's just one of their withdrawal symptoms.
How long does it typically take to stop a baby having withdrawal symptoms?
Up to 6 months, sometimes even up to a year.
I can't even imagine what you go through and what you see on a daily basis and how hard it must be.
Most days, you go home okay. A few days you don't.
So we would be lying to ourselves if we pretend that this opioid crisis is not impacting us in our professional roles. It's impacting us, and it's important to consider in our different CISM and peer support teams to have discussions about how this is being responded to, and if it's even being considered in terms of using your tools and considering it as a critical incident. And we know how this impacts first responders, and so when we've talked about addiction in first responders, we usually focus on things like alcohol, and it's something to have on your radar that we're seeing more and more addiction in first responders to opioids. So now let's talk about how we can use the tools in our professions to deal with this. We consider pre-incident training in CISM, and the same can go for the opioid crisis with education, prevention, and preparation. Part of education is what we're doing here today, is understanding what's causing this crisis, so it's not a mystery, so it's not as frustrating, so you have better tools for how to respond to it, as well as be involved in prevention efforts and knowing how to respond to overdoses. So just a little bit about how DEA is approaching education and prevention. You know, DEA is responsible for enforcing the drug laws. Most people think of the agents that are kicking down doors and doing drug raids, and that is certainly part of it in terms of going after illegal drugs. But the other part of DEA that a lot of people don't know is diversion, which is going after manufacturers, distributors, doctors, pharmacies that are irresponsibly getting these drugs into the hands of patients. We also see that, like we talked about, for new heroin users starting with prescription pain medicine, we also see that a lot of young people are starting to get those pills from where? Friends, parents, medicine cabinets. So the National Drug Control Strategy is really focusing on incorporating prevention and treatment, not just reducing drug availability and enforcement, but understanding that you take those drugs away, it doesn't take the addiction away, and that all of us need to be involved in encouraging prevention and treatment. So the DEA has several educational programs that are online and free for people to use that are focused on teachers, schools, parents, youth. Operation Prevention is specific to opioids, and you guys are welcome to use these. I also encourage you to look into your own communities and see what resources are there, especially if you're coming across parents and trying to provide them with information so that they can safeguard kids, because the drug experimentation that maybe you and I were exposed to in high school, middle school is not what kids right now are being exposed to. And the overdoses in young people, especially, is because of drugs being laced with fentanyl. Who knows what take back is? Yes, sir, in the back. What is it?
It's just the day when you can go to a designated place to start that patient.
Absolutely. Gold star for you. So we have it twice a year. This is where usually it's police departments, just because of legalities of handling the drugs, that host a site, but certainly other agencies and community groups can be involved, where the community has an opportunity to go and get rid of unwanted medications and get information. And it's just a positive community involvement. So if it's something you're not already involved with or your agency's not involved with, look into it. The last event, we collected nearly 1 million unused medications across the US. Stuff that was sitting in people's medicine cabinet, because what happens when you go to the dentist, right? You get some kind of work done and they give you a nice little bottle prescription, and what do you do with that? Put it in your cabinet and save it because you don't know what to do with it, and you might need it down the road, right? And it just becomes, unfortunately, a means for someone close to you to get access to that. And it still is the most common way that people are getting access to prescription drugs that are not theirs. Other ways that we have opportunities for teachable moments, harm reduction. A little controversial for responders, a little easier for public health and social service people in terms of making it safer for people that are using drugs, as well as making it safe for the general public health. So we have Narcan. Who can explain what Narcan is? Opioid reversal, overdose reversal, right? It's blocking the receptors in the brain that are going to receive those opioids. So it's going to stop someone from overdosing. But is this a permanent fix? No. And this is something that is kind of a misnomer for a lot of people, and the paramedic in the video touched on it, is you need to get somebody to medical treatment, because once that wears off, if somebody has real potent drugs in their system or a lot of drugs in their system, they could overdose again. We also have medical interventions and referrals, so if you're in those services, it's an opportunity to talk with people about different treatment resources. And we have restorative justice, drug courts, opportunities to connect people to treatment. A lot of people don't know what kind of treatment they need. So detox is the first part of treatment. People say this is the worst part of it, is getting the drugs out of their system. And this is where most people are not successful in getting through to the other part of treatment, which is medication-assisted treatment, MAT treatment. This is the golden standard for treating opioid addiction. It is just for opioid addiction. So we have a lot of officers that sometimes assume that if somebody is using drugs or substances, that a detox facility that might be focused on alcohol is an appropriate place to take them. It might be the only option, it might be a good first option, but connecting them to the MAT treatment that's going to help reduce their cravings, reduce the effects of opioids, and give them a chance to stay sober is really what they need. So if you're not already familiar with MAT treatment, SAMHSA has phone number and website where people can search by zip code and find the MAT treatment in their communities. This may not be something that you as a professional use, but certainly can offer it to people you're encountering, family members who are trying to get somebody connected to treatment. And being able to understand how to respond to overdoses. So most people in this room are in medical or firefighter or paramedic roles, so most of you are very familiar with what an overdose looks like. What is the number one sign that you're looking at when you go to an overdose to try and see if it's an opioid overdose? Okay, so he said not breathing and pupils. And that's really what's happening when someone is overdosing on opioids, is it's suppressing their breathing, especially if they have other things on board like alcohol, muscle relaxers, other sedatives. So the pupils, what happens to the pupils? Pinpoint. And that's usually what the number one thing that people are looking at is the pupils to see if it's opioid related. If they use Narcan on them and they don't respond right away, and they use more and they're still not responding, what does that say to you? Right. Absolutely. So in our professions, the other thing that's coming up is potential exposure to these drugs.
It was a routine traffic stop on the Canyon Road Bridge behind me that took a dangerous turn when the officer transported the suspect to the law enforcement center.
This is how rescue personnel found the officer outside the law enforcement center in his police cruiser. Fort Dodge Police asked that we not show his face due to medical privacy issues.
He was essentially almost fully unresponsive to the point where he was very lethargic and his eyes were closed.
It started here on Canyon Road just minutes earlier when the officer stopped the vehicle Sunday evening. He arrested Caleb Potter for driving under suspension and giving false information. While searching her vehicle, he encountered a bag containing a brown powder believed to be fentanyl.
He was handling the container that the powder was in and had disturbed the container open enough to where it might expose whatever powder is in it, potentially sending the particles airborne.
The few minutes it took to drive the suspect from the bridge to the jail was long enough for the officer to be overcome. He radioed ahead for help. When rescue personnel arrived, the officer was in his cruiser, barely conscious, with the car in gear, his foot on the brake. Medics gave the officer 2 doses of Narcan, an opioid overdose reversal drug, in the ambulance, and more at Trinity Regional Medical Center's emergency room. Captain Grunberg says this just highlights dangers police face every day they are on the job.
Pretty intense situation. From what medical staff have informed us, he's pretty lucky.
Captain Grunberg says he was told Narcan saved the officer's life. In Fort Dodge, Marcus McIntosh, KCCI 8 News, Iowa's news leader.
So fentanyl exposure is something that we should all be concerned about, we should be cautious with, but we also need to understand the true information about it, because when it first was becoming prominent, there was a lot of misinformation, a lot of scary information going out that also was getting responders hesitant to do their job. And it's important to remember that with fentanyl, the transdermal touching it and overdosing is extremely unlikely. What is it that's usually causing these overdose incidents? What means of exposure? Inhaling. So we don't want first responders to be scared to the point that they're not reacting when they go to overdose scenes, but to take the proper precautions. One thing that's very important to remember is just how it's getting into your bloodstream. So one of the worst things you can use is any kind of hand sanitizer, which is so common for first responders after being at a scene, but what is the hand sanitizer doing to your pores? Opening it up. So if there is any kind of powder fentanyl that's there, it's just giving it an easier access into your bloodstream. So we tell first responders to be cautious with using any kind of alcohol-based hand sanitizer or wipe, and soap and water is really the best thing. To keep in mind that the person needs medical treatment. If you have a colleague that is experiencing symptoms, to get them to medical treatment. Don't let them tough it out, because you want to ensure that they haven't been exposed and that they're going to be okay. And also when it comes to field testing, we don't have law enforcement in the room, but if you have any interface with law enforcement, reminding them of the dangers of field testing it rather than containing it and sending it to a lab to verify what it is. And responding to overdose deaths, whether the person overdoses, whether a person survived or if they died and it was completed, is understanding that's a criminal investigation. These cases really are being taken more seriously rather than it just being a death investigation, but possible criminal charges related to the person that supplied the drugs, especially if it's prescription drugs and can be traced back to doctors. So if you're in a position to preserve evidence, document evidence, any kind of information you can give to law enforcement that you've come across on a scene or as a provider in terms of who that person might be getting the drugs from is very important in terms of trying to, in your roles, help prevent further overdoses with that person and other people. We see something called a fentanyl footprint, and this is where you see a cluster of overdoses in an area. Has anyone had to respond to this kind of thing? How many overdoses was it?
It was 20 in 24 hours.
20 in 24 hours. So if you see 20 overdoses in 24 hours, what does that indicate to you? What's happening in the community? Bad batches in town. So we can shrug our shoulders and say, oh, well, it'll pass, or we can try and get information and try and stop that from further spreading or coming back again, right? So all these things we can work together to try and have some better solutions to this. Now, when it comes to CISM, if you have a colleague who has potentially overdosed on fentanyl, who thinks that is a critical incident? Does anybody in their agency, have you had experience where peer support or your CISM team has been deployed following this kind of incident? Have you had overdoses where you think they could have been deployed? Awesome. So really the whole point of this conversation is within your own teams is to discuss how things related to the opioid crisis, especially when it affects your own personnel, how you're responding to it and how you might use things like diffusings and debriefings to respond when there has been an exposure in the field or when people have responded to maybe a particularly disturbing overdose. Let's say that it involved a young person or something along those lines. Right now, what we're kind of seeing is that it's being overlooked, kind of pushed aside as not really a big deal, and it's just something that's part of the job, right? It's not being classified as a critical incident. It's not being seen as contributing to these other factors that we're concerned about with CISM. Of course, the other part of CISM that a lot of us struggle to be good at is the follow-up component. So if you have colleagues that have experience an exposure or responded to a bad incident, are you following up with them? Do you know the resources that you can provide to them to get proper support? Are you incorporating resiliency training into your teams so that when people are experiencing any kind of stress and trauma, they're understanding how to deal with that because of the lingering impacts? And we also talk about engagement. Does anybody's team practice engagement? In our responder roles, we often don't get to see positive outcomes. We don't have positive interactions. Does anybody following an incident purposely set up some type of engagement? Maybe it's the person involved gets to go and interact with the person once they're out of the hospital or something like that. Any examples of that? I know probably the most common example is, let's say you responded and did CPR and the person survived, and at a later date you have an opportunity to go meet that person. And especially when it comes to dispatchers not getting to see end outcomes and being able to see survival and not just the negative outcomes, we really encourage engagement. So I'd like to leave with a little video that shows that with a group of people that are recovering from addiction who are making a point of going and visiting first responders to thank them for saving their life.
We from MBH, we gathered together, we came up with this group, which is WAR, and we are recovery addicts who get together, and we are trying to do a little community stuff to kind of, get out there that the other side of addiction, that we do recover. And then we also wanted to come and thank you guys, first responders, for all the help that you guys do with the Narcan. A lot of us have been brought back due to Narcan. I know I personally have 3 times, so I wouldn't be here today if it wasn't for people like you.
Well, we appreciate it. And I know we hear the passion that this team, we've reached out to the guys. Our number one priority when we do this is to make sure you're safe. So on behalf of the medical party, we do thank you. We wish you all the luck. And we hope to never see you again in that state. And, our prayers go out to you and your recovery.
Thank you.
Okay, so I wanted to end with that to remind you that in your different roles, you can have an impact in this crisis. Hopefully from this, you have a little bit better understanding of what's driving the crisis and can think about in your role how you can use CISM tools to respond both for colleagues and the community.